This debate was arranged in a rather unusual way. We don't have just a straight motion, for and against. I have to defend one view, and Christina has to defend another view. So I can't pick on the words in order to try and refine my point of view. But you can see I have to support the notion that yes, they are too strict. There is a larger group that should benefit from left atrial appendage occlusion, and it should be strongly recommended too. Firstly, you have to see that I have some potential conflicts, and it's important on this occasion because I want you to appreciate that I too am in part responsible for these guidelines. So it's not all Christina's fault. Almost, but not all his fault. So let's move ahead. This is my honorable opponent, as they say. You can see he looks a very worried man. He obviously is finding it very difficult to contemplate the whole issue of left atrial appendage occlusion. I'll show you, for example, what he looked like as a young man before he had to grapple with all of this problem. But see how things have changed now. He's a very, very different person, having to cope with all the problems of left atrial appendage occlusion. These are just 20 of the guidelines that have been published since 2010, all relating to atrial fibrillation, several of them mentioning left atrial appendage occlusion, but this is the one that we're going to dissect in some detail. And this is the 2016 ESC guideline. Now you can see that this guideline is contributed to heavily by Christoph Diener, so he has to support what's in the guidelines. And I'd also like to point out that this guideline is unusual because it's very heavily dominated by surgeons, unusually. And that will, in part, explain some of the unusual features related to this guideline. Now, this is the specific recommendation that I'm supposed to argue against. Left atrial appendage occlusion may be considered for stroke prevention in patients with AF and contraindications for long-term anticoagulant treatment. It goes on to give an example. Those are the previous life-threatening bleed without a reversible cause. Now, this is not all that different to the guideline that I was primarily responsible for. Interventional percutaneous left atrial appendage occlusion may be considered in patients with a high stroke risk and contraindications for long-term oral anticoagulation. Well, the new guidelines got rid of the idea of high, but it has introduced the idea of life-threatening adverse effects related to anticoagulation. So it's pretty simple. And you'll notice that the evidence is quoted as a level of evidence B, and the recommendation is weak, 2B. But surely there's been some change in the evidence between 2012 and 2016. Well, according to PubMed, as you can see there are 527 papers on left atrial appendage occlusion. And this is what it looks like, and you can see that between 2012 and 2016, there have been 2/3 of these 527 papers published. And yet the guideline has not changed one jot. So presumably you're not reading. Is that the problem? Possibly. Well, let's have a look. I don't want to quote a lot of the evidence. I just want to say what the guideline committee obviously made of the evidence. Clearly, this is David Holmes' meta-analysis, individual patient-based meta-analysis, PROTECT AF and PREVAIL. Many of us point to all of these features. So, for example, massive reduction in hemorrhagic stroke, A strong tendency to the reduction of all-cause death and major bleeding, which is not procedural related, is obviously largely reduced. What the guideline points to is this detail, that ischemic stroke or systemic embolism is a point estimate to the right, and it is just or just not statistically significant. But this issue of ischemic stroke, there's more data on it now, more data in 2016 when the guidelines were produced. I don't want you to spend much detail looking at that, at this data, but you can see, for example, that all strokes, well, you could see, not there anymore, you could see on the right at least that all strokes, is it back? No, all strokes are occurring at about a frequency of 1.2, and if you look at the rate of strokes with all of the anticoagulants and the left atrial appendage occlusion, you can see left atrial appendage occlusion at 1.1 for ischemic strokes lies right in the middle of the results with all the NOAC therapies. So there is no essential difference according to this patient meta-analysis with 2,800 cases. So we have to look at the context in which this recommendation is made. You can see the recommendation we're discussing. It's in bold type. But I'd like you to look just below that. There are two other recommendations. Surgical occlusion or exclusion of the left atrial appendage may be considered for stroke prevention in patients with AF undergoing cardiac surgery. No mention there of any particular disadvantage from anticoagulation, no life-threatening bleeds. Well, perhaps that's all right. The surgeon's there, he might as well lop it off. But let's have a look at the next recommendation. Surgical occlusion or exclusion of the left atrial appendage may be considered for stroke prevention in patients undergoing thoracoscopic AF surgery. Well, that's quite a big thing to ask, to be able to take off the left atrial appendage thoracoscopically in a patient with no qualification for needing to have life-threatening bleeds or a contraindication to anticoagulation. So I thought it was appropriate to look at the rest of the words, discussing, for example, what possibilities of indications there might be. But there's not really any mention of any potential indications, even in the text. It says, although the concept of left atrial appendage closure seems reasonable, the evidence of efficacy and safety is currently insufficient. It says, however, in the absence of controlled clinical data, this recommendation is based only on an expert consensus. So it goes on to say, additionally, adequately powered randomized studies in patients with high stroke risk and long-term follow-up comparing interventional percutaneous surgical LA closure with OAC therapy, including NOAC drugs, are needed. And it goes on then to say the need for lifelong aspirin after placement of left atrial appendage closure devices removes the advantage that they may have. And finally, it says present interventional left atrial appendage closure is not indicated simply as an alternative to OAC therapy to reduce stroke risk. So it's pretty damning. Everything it says is there's no other indication except possibility of life-threatening bleeds on anticoagulation. But other people have a different view. For example, there's a tremendous unmet need. And what is that tremendous unmet need? Left atrial appendage occlusion to address the unmet needs of stroke prevention in atrial fibrillation. Nobody seems to acknowledge in the guidelines discussing the left atrial appendage occlusion that there are major difficulties with anticoagulation. Only half of our patients are anticoagulated. Doctors are giving low doses of the anticoagulants. Adherence to therapy is extremely poor. Many patients give up taking anticoagulants within 1 year. Major bleeding occurs in a high proportion, And about 5% of the overall mortality is due to major bleeding. So anticoagulants are not for free. There's a lot of problems with their use. So what do other guidelines say? Surely the group writing the guidelines for the ESC looked at other guidelines. Well, the NICE guidelines are interesting. They start off by saying percutaneous occlusion of the left atrial appendage is efficacious in reducing the risk of thromboembolic complications associated with non-valvular atrial fibrillation. Now, the next paragraph is where it cuts to the chase. It says the current guidance recommends that patients should be selected by a multidisciplinary team, including a cardiologist and other appropriate clinicians experienced in the management of patients with AF at risk of stroke. In other words, sort it out for yourself, knowing that this is an efficacious treatment. What does the customer, what do the doctors think? Well, here's just one list of indications in one registry. And you can see, yes, it's true that the majority of indications are for previous major bleeding or a high bleeding risk or polypharmacy or strokes on warfarin, but other indications are being chosen by patients and physicians. So we shouldn't think that we have to stick entirely just to previous major bleeding or very high bleeding risk. What do the Americans say? Well, in their guidelines, you can see section 3.4 was on cardiac surgery, left atrial appendage occlusion and excision, and they're going to make some recommendations on occlusion. What do they actually do? They forget about it. They make no recommendation at all. They say surgical excision of the left atrial appendage may be considered in patients undergoing cardiac surgery. And they did that, of course, because the FDA had not reached an opinion. But we don't have to worry, Chris, about the FDA. And anyway, they have reached an opinion now. And why didn't you read this? The FDA said the Watchman device is indicated to reduce the risk of thromboembolism from the left atrial appendage in patients with non-valvular AF who are at increased risk of stroke based on risk stratifiers and are deemed suitable for warfarin and have an appropriate rationale to seek a non-pharmacological alternative to warfarin. They don't require life-threatening bleeds. They don't require any other stipulation other than you think it's not appropriate for the patient to take warfarin, even though they may be suitable for warfarin. So what do the cardiologists think might be the indications? Well, I think we could go through a whole list. Intolerant to anticoagulants, non-compliant with anticoagulants, high stroke risk with a high bleeding risk, thromboembolic events whilst taking anticoagulants, patients who can tolerate both should have a choice, and patients undergoing ablation techniques, or particularly if the left atrial appendage is isolated, or mitral clips, for example, they should all be seriously considered for left atrial appendage device occlusion. And we can see that some of our colleagues in cardiology have made recommendations in the field of atrial fibrillation, but this comes from the ESC, EACS guidelines on myocardial revascularization. They recommend consideration of this technique in patients who are having a PCI and are on dual antiplatelet therapy and anticoagulants for atrial fibrillation, totally unmentioned in the ESC AF guidelines. So let's have a look at what the neurologists recommend. I think, Chris, this will particularly interest you. This is the neurologist, of course it's the American neurologist, and as you said to me yesterday, they're not a lot of good. And I totally agree. Look at their recommendation. They say the usefulness of closure of the left atrial appendage with the Watchman device in patients with ischemic stroke or TIA and AF is uncertain. But fortunately, it's a weak recommendation, but with moderately good evidence, and it's a new recommendation. So they moderately, strongly recommend, on the basis of moderately good evidence, that we really don't know what we're talking about. And I think that's a wonderful, wonderful recommendation. So, just to summarize, the ESC say that the indication is for those that do need an oral anticoagulant but can't take one. The FDA says that the indication is for those who can take an OAC but won't take one. The ASA, I just showed you, is that we don't know what we're talking about, and NICE says you can work it out together. There's no hard and fast rule. So, Chris, the ESC guidance, you must admit, not good enough. Thank you.
Thank you, John. This was a strong statement. Professor Diener, now your title is No, the ESC guidelines. So what you wrote together with colleagues are right. LAA occlusion should be limited to oral anticoagulation contraindicated patients, however this is finally defined, but it's a very strict and limited area. Please.
Yeah, ladies and gentlemen, I knew beforehand you should never go against John Camm, because you will lose whatever you say. So you just heard about the new guidelines and you heard the statement. Now let me comment that I did not vote, I abstained from point 1, 3, and 4, because I have no idea about cardiac surgery, so I cannot comment on any of this. But I was instrumental in part 2. I won't tell you in detail which of the text is mine originally. But I have to say, John, we were 17. So the vote at the moment is 17 against 1, because 17 of the most well-known clinicians and scientists in the field supported this recommendation, and John is the one who is against it. Now let me come back to the 2 trials that were mentioned. You remember the PROTECT AF trial. Now trials are usually run by 2 purposes. There are the scientists on one side, which have a scientific question. And then there are the marketing people of a pharmaceutical company or device company, which also have their influence. Now, what are they doing? The scientists usually restrict something because they say, we want a new therapy for the people who need it most. The marketing people have euro and dollar signs in the eye, and they said, we want everyone. If we can get the 2% of people who have atrial fibrillation in the world, and we can use LAA occlusion in all of them, we are safe for the next 30 years. And this might explain why the 2 original trials were designed as they are. So the only inclusion criteria were atrial fibrillation, JETS risk factors, and they had to be eligible for warfarin because you needed a comparator, so the treatment required a short-term warfarin treatment. And then there were a few exclusion criteria. Medication, as you know, at that time it was warfarin plus aspirin, and then it was clopidogrel, aspirin, and long-term aspirin. So what's the purpose here? All comers were recruited. So they did not differentiate between people who had a very high risk or needed this device compared with everyone who could be put also on warfarin. And what was the outcome? Ladies and gentlemen, when we look at these trials, we first always look at the primary endpoint. And the primary endpoint clearly said there is no difference, there is no benefit. Now, what is the rule of statistics? Once you have no difference for the primary endpoint, every other endpoints are purely hypothesis generating. Let's look at the second trial. The second trial had basically almost the same inclusion criteria. They had the same concomitant medication. Again, it was a trial recruiting all comers, not particular patients where you would possibly expect a benefit of the closure of the atrial appendage compared with anticoagulation. And again, this trial was negative for the primary endpoint. Now, if you have 2 negative trials, what do you do to find something which you can sell to an audience? You make a meta-analysis. But that's not the way these data should be analyzed. I would like to remind you, meta-analyses are fine to define a population for a future study. They are hypothesis generating, but they will not drive your decision which patient should be treated by what. So if you find a subgroup that might have a benefit, you have to do a second trial to show that it is really true. I would like to remind you, we had several meta-analyses in antiplatelet therapy which predicted the superiority of one particular treatment against the other one. Highly statistically significant. And then we did the randomized trial, and it was not true. So never conclude from meta-analysis on how you treat your patients. Now, why did we decide to go for people who are usually untreated? And this is, I think, the most important figure because it shows what the real issue is here. Now, this is the rate of ischemia, of stroke with LAA occlusion. And this is the rate of people who are untreated, who have clear contraindications for long-term anticoagulation, or people who can only take aspirin, not necessarily long-term for 10 years, they need to take it, as you know, at least 3 or 6 months. This is where the winner is, if you compare these two groups. Why are you going against these where the risk is the same? What is really the benefit? This is where you want to go. And these are the bleeding risks, again, for comparison. So, ladies and gentlemen, which people are the best candidates for LAA occlusion? And I have to admit, we have no randomized prospective study which shows that these people are really the ones who have the benefit. And what we desperately need are clinical trials. We have registries ongoing, but this is always only the second best option we have. I totally agree with John. Patients who refuse oral anticoagulation, that's about 10% of all patients with AFib. They will say, I will never take this drug because my mother died from an intracranial bleed. And then patients who had a TIA stroke, why? These are the ones who have the highest risk of a recurrent stroke, and if they have a high risk on a bleeding risk on an oral anticoagulation. Patients with a history of GI bleed, where the cause of GI bleed cannot be removed. And there are a number of conditions where this is the case. Patients with non-traumatic intracranial hemorrhage, because traumatic intracranial hemorrhage usually can be very well handled. And then patients with a high risk of intracerebral hemorrhage, and this would constitute, for example, amyloid angiopathy. The only prerequisite, the patients need to take, as you know, dual antiplatelet therapy for 45 days and then aspirin for 3 to 6 months. But long-term, they are no longer treated with antithrombotic therapy. And I think these are the kind of patients that we meant when we said in the guideline, these are the ideal patients who should be considered for LAA occlusion. Now, despite what I said, hypothesis generating, at least we have data from 2 meta-analyses. And this is a meta-analysis which compared all the available data we have of left appendage occlusion against no warfarin. So the patients who do not qualify for anticoagulation because they have contraindications. In this case, LAA occlusion is highly superior, a 50% risk reduction. But these are patients who qualify for oral anticoagulation. And now we have a trend in the wrong direction. People on anticoagulation are doing even better than people on LAA occlusion. And that's all the published evidence in this kind of meta-analysis. So, ladies and gentlemen, my conclusion is patients with AF have no benefit of LAA occlusion, most probably, compared with NOACs. We have no head-to-head comparison, but NOACs have definitely a lower risk of intracranial hemorrhage. And patients at risk of bleeding or a history of major bleeding might have a clear benefit from LAA occlusion. So, ladies and gentlemen, I think the ESC guidelines are right, and we will only be able to change the guidelines if we have more data from properly conducted controlled trials. Thank you very much.
Thanks a lot. John, may I ask you to come to the podium? I would say, let's restart the voting now, because now we are in the competitive phase, and after the voting you have the option for a short rebuttal, because I think then we can make more handshake situation. Can we repeat the voting, please? Same question, it's on.
Headshake or
so one,
handshake?
they are too strict, John's position, and two, for the Diener's position, they are right, they are all right. We have a lot of more colleagues voting now. When I see it, we were at 75 initially, okay. I think we started with a 66%, 33 situation, okay.
You win.
Well, I gained 1%. So.
Okay, I think this is close. I think this is a handshake, I would say. Thank you both, and I think you have a short option for, let's say, rebuttal, and how do you, well, outside this role, how do you see your position?
Well, I don't think we need to say very much. The guidelines are obviously trying to limit the explosion of the use of a device without supportive evidence. In fact, the guideline itself is not supported by any evidence much, but it is a conclusion, a rather pragmatic conclusion, from an assessment that says that the devices of this nature seem to be effective or efficacious to some extent in various populations. But the population chosen is one that's not yet been adequately studied. And we all have to recognize, in my view, that many patients are not effectively anticoagulated, come what may. You know, we're talking about people giving up anticoagulants at a rate of 25% to 50% a year. We're talking about people not using the anticoagulants, taking them. They're something of the order of 30% are not taking the anticoagulants that they are prescribed. We're talking about doctors who are reluctant to use anticoagulants because they fear the complications of anticoagulants. So there is a huge population of patients who are simply not anticoagulated. If they were, they would do relatively well, but they're going to do badly. And we do need alternatives that do not depend simply on the patient taking the pills. And I think that this constitutes such a therapy that takes the responsibility off the patient and offers an effective treatment. So I see in the future that this sort of therapy will be used much more. And obviously, as it's refined, it becomes safer, quicker, and cheaper, and so on and so forth. All of those things will lead to more use of such a therapy.
Thank you.
Yeah, I think the issue in the near future is not the science, and it's not cardiologists and neurologists. The issue are the reimbursement people. Because they will come and say, look at your registries. The majority of your patients that you are treating with the device were not in the randomized trials. So obviously in everyday practice, you treat a totally different population than you did in the randomized trials. And what is the evidence that this population really benefits? You have only indirect comparisons with databases, and that's not good enough. I just want to give you another example. You all know the Reveal XT. We had got a letter from the reimbursement people last week which said, you showed that you are better in identifying atrial fibrillation, but you have not shown that you reduce the risk of stroke. We will no longer pay for it. This is what's coming. And this is not the other reason why we need data and evidence. It's not only for our patients and for the benefit of our patients. So we have to be aware, and this will come in all countries. I can promise you the reimbursement people want to save money wherever they can, and if we don't provide them with proper science and proper data, they will unfortunately win, and our patients will lose. Thank you.
Thanks a lot. Big applause to both discussants. Thank you. And we will break until 3:10 and come back 3:10. Please don't forget the EBAC evaluation and pick up your certificate. Thank you.